So, good evening, everyone. Hope you are doing well. In today's session, we will be looking at part two of the SCE and European Board exam recall. This was based on the 2021-2022 exams, and we'll be discussing around another 10 question-based themes which had appeared in the previous exams. So, in the first part, I had discussed 10 question themes, and in this, there will be another 10 themes which will be discussed. And of course, they are very high yield for the upcoming 2023 exam. So let's start right away. So the first question theme is surrounding the sick day rules in a type 1 diabetic patient. So typical type 1 diabetic patient with blood glucose of 15 millimole per liter was mentioned in the question theme, with the blood ketones of 1.6 millimole per liter, both of which are obviously high. And the question was asked, how much of the quick-acting insulin has to be given as supplemental quick-acting? So let's see how to apply the Daphne rules to calculate this amount. In terms of guidelines, Daphne, or the diet adjusted for normal eating, is the one which applies to be able to solve this question. And we'll look at the sick day rules surrounding the type 1 diabetic patient. So this is the sick day rules for a standard Daphne patient. We'll be also looking at an insulin pump patient in the next slide, but this is for the based on the question, which the patient was a type 1 diabetic patient on basal bolus insulin. So this is a standard Daphne patient. So feeling unwell, check blood glucose and ketones. Now, no significant ketones means that will be less than 1.5 millimole per liter on the blood check, negative or trace on urine check, and the blood glucose may be within target or above the target range. Now this can be classed as a minor illness. On the other hand, if significant ketones is present, which is 1.5 millimole per liter or more on blood check, more than a trace on urine check, and blood glucose above the target range, usually about 13 millimole per liter, that can be classed as a severe illness. So in our patient scenario, we had 15 millimole per liter. This was a type 1 diabetic patient on basal bolus insulin regimen, basically taking the bolus insulin 3 times a day and the basal insulin once a day in the night. His ketones was 1.6 millimole per liter, which is definitely significant ketonemia. So he should be classed as having severe illness. So in both the scenarios, minor or severe illness, we should advise the patient to sip sugar-free fluids at least 100 ml per hour. In terms of minor illness, we should advise the patient to check blood glucose and ketones every 4 to 6 hours. Now, this itself has appeared as a question in previous many exams. On the other hand, if the patient in the scenario has a severe illness, then he should make sure to check his blood glucose and ketones every 2 hours. Now, in cases of minor illness where the blood glucose and the ketones are checked every 4 to 6 hours, first and foremost, the patient should take the usual insulin to carbohydrate ratio if eating. Now, basically, CP is a carbohydrate portion. One carbohydrate portion, or one CP, is approximately equal to 10 gram of carbohydrate. Usually, people use 1 unit for 10 gram. Of course, depending upon the sensitivity to the insulin, this ratio can be higher or lower. But in the scenarios where patient has got a minor illness, he should make sure to use his usual insulin to carbohydrate ratio if eating, which he is usually using. If your blood glucose is above the target range, use quick-acting corrections even if you're not eating. Okay, so this is very important. If your blood glucose is above the target range, use quick-acting corrections even if you're not eating. If your blood glucose is within the target range, you may only need basal insulin if you're not eating. This is all in scenario for minor illness. Take your usual basal insulin, but you may need to consider increasing the basal insulin by 1 to 2 units if you continue to be unwell for more than a day. So these are all the steps which are involved in management of a minor illness. On the other hand, If it is a severe illness, like in our patient scenario, we should be checking the blood glucose and ketones every 2 hours. I mean, we should advise the patient to check his blood glucose and ketones every 2 hours. He should be knowing, of course, to calculate his total daily dose. So what is the total daily dose? It is a sum of the basal plus the bolus insulin. So for example, if the patient is using approximately 5 units 3 times a day of the quick acting insulin plus 15 of basal at night, then the total daily dose will become 30. In the scenario, if the blood glucose is between 1.5 to 3, or if the urine ketones is small to moderate, which is plus or plus 2, then the patient should take 10% of the total daily dose. So for example, if a patient is taking total of 30 units per day as a total daily dose, then 10% of 30 will become 3 units. And he or she should take this 10% of the total daily dose as supplemental quick acting insulin every 2 hours. Every 2 hours. Okay. So this is in scenario of a severe illness. And this was basically the answer to our question theme. Our patient had 1.6 millimole per liter for the ketones. 10% of the total daily dose as supplemental quick acting insulin every 2 hours, plus the usual quick acting insulin to CP ratio if eating, plus of course the usual basal insulin. On the other hand, if the blood ketones were mentioned as more than 3 millimole per liter, or if the urine ketones were large in amount, like plus 3 or plus 4, then the advice is to take 20% of the total daily dose as supplemental quick acting insulin every 2 hours. So suppose if the patient is taking 30 units per day total daily dose, then 20% will become 6 units. So in this scenario, 20% of the total daily dose every 2 hours, plus the usual quick acting to carbohydrate protein ratio if eating, plus the usual basal insulin. In both the scenarios of minor or severe illnesses, if the patient is vomiting or unable to keep fluids down or unable to control your blood glucose or ketones, the patient should go to the hospital as an emergency and should never stop taking the basal insulin. So this is as per the latest Daphne, which was uploaded in May 2020. Now, what we saw was a scenario for the Daphne guidelines for a standard patient. So we talked about Daphne for a standard patient. So these are basically patients who are on basal bolus insulin. But what are the sick day rules for pump patients, those patients who are on insulin pump? So similar classification of the minor or severe illness. So less than 5 minor illness, more than 1.5 severe illness in terms of the blood ketones. Take a bolus correction using your pump and recheck blood glucose and ketones in 2 hours. This applies for pump patients' sick day rules. Blood glucose remains unchanged or has risen further, then take further corrective dose of quick acting insulin using a pen. Change the cannula, infusion set, and insulin reservoir. Check blood glucose and ketones every 2 to 4 hours and use your pump to bolus the insulin. Sip sugar-free fluids at least 100 ml per hour. Use your insulin to carb ratio of eating. Again, if your blood glucose is above the target range, use a corrective bolus even if you're not eating. If the blood glucose is within the target range, you may only need to increase your basal insulin if you're not eating. If your blood glucose is persistently above the target range, consider an increase of 10 to 20% in the basal insulin by using an increased temporary basal rate. So in pump patients, we can increase the basal rate by 10 to 20%, which will be like a temporary basal rate increase to combat this situation. On the other hand, if it is a severe illness in a pump patient, then again take supplemental quick acting insulin based on the total daily dose scenario, like we discussed in the previous session. Make sure to check the blood glucose and ketones every 2 hours. Sip sugar-free fluids at least 100 ml per hour. Calculate your total daily dose. If the blood ketones is between 1.5 to 3 or urine ketones is small to moderate, can give 10% of the total daily dose as bolus every 2 hours, plus the usual insulin to carbohydrate ratio of eating. One important thing here is increase the basal insulin by 30% using a temporary basal rate. So basically you will override the bolus calculator. So this is an added thing when we are talking about sick day rules for a pump patient. On the other hand, if the blood ketones is over 3 or the urine ketones is large, +3 to +4, give 20% of the total daily dose as bolus every 2 hours, plus the usual insulin to carb ratio if eating. And we should make sure to increase the basal insulin by 50% using a temporary basal rate and override the bolus calculator. So these are the important points when we talk about sick day rules for the pump patient. I mean, the sick day rules for a standard Daphne patient was asked in the previous exams. You might very well get a sick day rule for a pump patient to be applied. If you vomit or unable to keep fluids down or unable to control your blood glucose or ketones, you must go to the hospital to the emergency. You must never suspend or stop your pump. So these are also published in May 2022 in the Daphne website. Let's look at question theme 12. Here we had a typical patient with history and biochemistry suggestive of hyperthyroidism. And a radioiodine uptake scan was suggestive of toxic multinodular goiter. And the question was asked about what is the recommended dosage of radioiodine in this context. They love to ask this question scenario, and we should know all the doses recommended for the different presentations of hyperthyroidism. The correct answer in this context was 500 to 800 MBQ. Let's look at all the doses, which is a very good table given in Oxford Handbook, latest edition, 4th edition. If it is Graves' disease, the first presentation, no significant eye disease, or moderate goiter alongside Graves' disease, the standard dose given is between 400 to 600 MBQ. That's the answer. If it is a toxic multinodular goiter in an older person, 500 to 800 MBQ, like this patient scenario, which we already had in the question theme. We should always be careful about patients with having heart failure, atrial fibrillation, or other concomitant heart disease, example cancer, when we are thinking about giving radioiodine. Toxic adenoma, toxic nodule basically, 500 MBQ. So toxic multinodular goiter has a higher dose, 500 to 800. If it is only a toxic nodule, around 500 MBQ. Graves' disease, first presentation, 400 to 600 MBQ. If it is severe Graves' disease with Graves' ophthalmopathy, of course, in this scenario, we should postpone radioiodine until eye disease is stable. Prednisolone 40 milligram to administer at the same time as the radioiodine and further 4 to 6 weeks. And in that scenario, that MBQ dose which will be used will be 500 to 800. We'll look at what applies in the scenario of Graves' ophthalmopathy. We have discussed this in detail in our Graves' ophthalmopathy lecture, which I had uploaded previously. Ablation therapy, that will be again 500 to 800 MBQ. Make sure that we are aware of other underlying medical conditions such as heart failure, atrial fibrillation, or concurrent medical disorders, example, psychosis. So these are the recommended doses across the different presentations for hyperthyroidism and the recommended doses for those activities for radioiodine. What are the contraindications for radioiodine? Young children because of potential risk of thyroid carcinogenesis, pregnant and lactating females. We should make sure to avoid conception for at least 6 months following radioiodine. Situations where it is clear that the safety of the other people cannot be guaranteed. If it is a Graves' ophthalmopathy, contraindicated radioiodine. There is some evidence that orbitopathy may worsen after administration of radioiodine, especially in smokers. In cases of moderate to severe ophthalmopathy, radioiodine may be avoided. Alternatively, if you have no other option, steroid cover in a dose of 40 mg, prednisolone should be administered on the day of administering radioiodine, 30 mg for the next 2 weeks, 20 mg daily for the following 2 weeks, and reducing subsequently to 0 over the next 3 weeks. I have discussed in detail about the latest UGOGO guidelines of Graves' ophthalmopathy in my Graves' disease lecture. I'll leave a link for that if you want to have a look at that. It is essential that euthyroidism is closely maintained following radioiodine to avoid worsening of ophthalmopathy. TRAb levels parallel to the course of orbitopathy. An elevated TRAb is an indication for steroid prophylaxis to prevent or progression of orbitopathy with radioiodine. Again, details of this has been discussed in my Graves' ophthalmopathy. Now, this is another 2 important paragraphs from Oxford Handbook, which is very important in context of the exams. of course, in context of the question theme of radioiodine treatment. So in general, 50 to 70% of the patients have restored normal thyroid function within 6 to 8 weeks of receiving radioiodine therapy. Many times they ask this percentage. Shrinkage of goiter occurs but is slower. The cumulative incidence of hypothyroidism in patients with Graves' disease and toxic multilobar goiter at 1, 10, and 25 years is 24, 59, and 82 respectively, versus 4, 15, and 32 for the toxic MNG goiter. What are the important caveats? Control of the disease may not occur for the period of weeks or few months. So radioiodine is not magic. It will take its own course of time to work. Sometimes it may take a period of 6 weeks to 3 months to see its full effect. More than one treatment may be needed in some patients depending on the dose given. 15% require a second dose, and a few patients require a third dose. So many times they ask this percentage. 15% may need a second dose of radioiodine. The second dose should be considered only at least 6 months after the first dose. Again, this question has been previously asked in the exams. Compounds that contain iodine, such as amiodarone, which block the iodine uptake for a period of several months following cessation of therapy. Iodine uptake measurements may be helpful in this instance in determining the activity required and the timing of radioiodine therapy. Females of childbearing age should avoid pregnancy for a minimum of 6 months following radioiodine ablation, and males should avoid fathering children for 4 months after radiation. Again, these two sentences has been repeatedly asked as questions in the previous exams. So that's why I specifically put these two paragraphs, because from this paragraph itself, two paragraphs itself, around 5 to 6 questions have been asked in the previous SCE and European board exams. Now, question themes revolve around the half-life of the different hormones. And in the previous exam, there were almost 3 to 4 questions in the last 2 years asking about the half-lives for the different hormones. And that's why I have compiled a list to be helpful for you in the upcoming 2023 exam. So half-life of PTH or parathyroid hormone, 3 to 5 minutes. Amiodarone, approximately 58 days, ranges from 25 to 100 days. I-123 isotope, 13 hours. I-131 isotope, 8 days. 99M technetium, 6 hours. Growth hormone, 14 minutes. Thyroxine, 7 days. Methimazole, 6 to 8 hours. Propylthiouracil, 90 minutes. Hydrocortisone, 100 minutes. Dexamethasone, 36 to 54 hours. FSH, 3 to 5 hours. LH, 30 to 60 minutes. Prolactin, 20 to 50 minutes. Testogel, which is a transdermal testosterone or oral testosterone for that matter, 1.3 hours. Approximately is between 10 minutes to 100 minutes. Nebido, which is an intramuscularly administered testosterone undeconate, half-life of 90 days. Half-life of testosterone cypionate, which is also injected intramuscularly, is approximately 8 days. Again, about insulins, half-life of endogenous insulin is 2 to 10 minutes. Half-life of IV insulin, which we give in the infusion, Actrapid, or regular insulin is 5 to 7 minutes. On the other hand, the basal insulins, the half-life for NPH or neutral protamine hectone is 4.4 hours. This is basically intermediate acting insulin. Insulin glargine U100 is 12 hours. U300 is 19 hours. Insulin detimel is 5 to 7 hours half-life. Insulin degludec U200 or U100, the half-life is 25 hours. What we need to remember in context of half-life for basal insulins, it generally takes 4 to 5 half-lives, approximately 4 half-lives to reach the steady state, and hence dosage adjustment should be made only after a steady state is achieved. So this is important when titrating the doses of basal insulin. We should be aware of the half-life, and again, all these are favorite questions to be asked in the exams. Again, ACTH or adrenocorticotropin hormone, 10 to 30 minutes. CH or corticotropin releasing hormone, 4 minutes. Thyroid stimulating hormone, 70 to 93 minutes. And the pregnancy hormone, HCG, 36 hours. So these were all the list of the half-lives which are commonly asked in the exams and have been asked in the previous 2 exams as well. So that's my preview. To get the full session, which is the full 10 question themes, this is the video number 58 in my full lecture series. And if you like to subscribe to my full lecture series, please get in touch with me. to my email, which is mazzyrules@gmail.com, or you can WhatsApp me directly to know about the subscription plan. My WhatsApp number is 00971557434794. Thank you so much. Thank you.